I'm Corrine. I'm Dr. Fletcher, and I thought I'd just tell you a little bit about me first because I've come in to knowing about MCAS from a slightly different angle, I think. So I'm a GP and a menopause specialist, and when I was seeing patients and treating them, often in the perimenopause, there were some that just got better with what I was doing, which was often HRT and lifestyle advice. And there were others that got really a lot worse. And there were some people coming along with really significant symptoms that were affecting their day-to-day life massively, to the point where some couldn't function and some hadn't been functioning for years before I saw them. And was trying to help these people and realized quite quickly that when HRT doses were increased, symptoms often got worse in this group of people rather than better. So that led me to, after years of being a GP, to realize that it was something called histamine intolerance. And then from there, found out about MCAS. So I'm not an MCAS specialist, but I have learned an awful lot over the last 3 years or so. And I tend to mainly see people in the perimenopause with either histamine intolerance or I think really a lot with MCAS. So that's me. And I think the fact that there's so many people here tonight, which is really surprising and makes me feel slightly nervous, is because there's not a lot out there about hormones and MCAS. And there are little bits, but there's very little research. And I think what's interesting to me is that there are more women with MCAS than men. And that when I talk to the ladies I see, uh, they may have had no symptoms, particularly up until the perimenopause, or they may have had little clues throughout their lives up to the menopause, for example, around puberty. And what's interesting is that puberty and perimenopause are two sides of the same coin in the sense that hormones are going absolutely bonkers at these times. And in my mind, there has to be a link between hormone health and MCAS. And it's not just the hormone changes and fluctuations, but I think also it can be quite stressful at these times as the body changes and often you don't necessarily know who you are anymore. And it can happen at times when life is busy anyway, so there's more stress, and I think that plays a part as well. So I'm not saying it's all hormones, but I think there's a real connection. And certainly in the perimenopause, what you're getting in the beginning, so the average age of the menopause is about 51, and perimenopause can be 7 to 10 years before that. And before that, you have quite a regular cycle usually. And there are some people that get a flare of allergy type symptoms or asthma at various points in the cycle, for example, ovulation and leading up to a period. So that would suggest that there's maybe kind of some hormone immune system thing going on. But it's often quite regular. And then in the perimenopause, in the early stages, you get a dropping off of the progesterone, and the estrogen often can reach quite high levels. It's fluctuating massively. So it's going very high and very low, often within quite a short time span. But it tends to be quite high. And then as you go through the perimenopause to menopause, the estrogen drops off. And what's interesting about that is that there are estrogen receptors everywhere in the body, and they're on mast cells. And so if you're having high estrogen spikes, then that seems to trigger mast cells to release all the active substances that they do. And we know that there's hundreds of them, and histamine is one of them, and heparin's another, and all sorts of inflammatory mediators as well. And so what you're getting is your progesterone dropping off. And we know that usually when there's estrogen receptors, there's progesterone receptors as well. And on mast cells, progesterone receptors seem to calm mast cells down. And so you're getting these kind of real kind of drop off of progesterone. So the calming hormones kind of dropping off. And then these spikes of estrogen, which can then cause increased histamine levels, heparin levels, all sorts of things can go up, and people can just feel absolutely dreadful. And I think what's really interesting to me is that there's a really long list of perimenopause symptoms covering every system in the body. And there's a really long list of MCAS symptoms, and there's massive similarities between the two. So I kind of think that there's some underlying process going on that's common to the perimenopause and MCAS. And I don't think anyone's really kind of got to grips with what's happening there. I think also what's happening is when estrogen levels drop off, then there's an impact on other things like gut health. And then that can also mean that there's an impact on the enzymes that help break down histamine. And we know that estrogen seems to reduce the diamine oxidase levels quite significantly this time. And so that again increases histamine levels, and that can have an impact on MCAS symptoms. So there's just a lot there to unpack, and I'm not ignoring puberty because I think that's another time when there's a lot of stress going on. There's a lot of hormone fluctuations. Estrogen seems to be there first, progesterone a bit later, when it starts kind of neck is kind of ovulating. And so for me, that's where we need to have some research, because I think people often get symptoms at these phases of their lives and not necessarily at the moment diagnosed with MCAS and therefore getting the treatment that they need. There are lots of things you can do, and I've seen people who've been really symptomatic and housebound in a few occasions get better to the point where they're leading normal lives. They may have to be slightly careful with what they eat, or just avoid kind of really key triggers for them. But I do think that if you can think of it as a diagnosis of a health professional, then there's a lot that can be done. And I think what I've learned through the women that I see is that you can think about using HRT for some, but you have to do it in a careful way. You have to go in quite slowly. Sometimes I'll go in just with progesterone, which isn't in any guideline for HRT treatment, but can be really helpful and can give symptom benefit in a lot of people. And then often you go in with some estrogen as well, because you don't really know what's causing the symptoms, whether it's perimenopause or whether low estrogen at that point, or whether there's an MCAS. It's the MCAS causing the symptoms. So often if you go in a little bit with some estrogen, you can get an idea of what's causing what, and then it's a little bit of a trial and error process, or really quite a lot often. But if you do things strategically, one thing at a time, you can often get to a point where you know what's working and why, and people can feel an awful lot better. And it's usually a combination of things. And I use things that the MCAS doctors use, so antihistamines. I use mast cell stabilizers, which can really help for some people. I go through a similar thing, a set of kind of steps as an MCAS specialist would do, but I also include HRT in that process. And the other thing that I've really noticed over the last 3 or 4 years is the lifestyle side of things is really, really important. So a lot of people, when I see them, are really on quite restricted diets. And they're quite scared to go to reintroduce foods that have triggered them in the past. And I do think that the issue isn't necessarily the foods, but it is the process that's going on in the body at that point. And I think it's important to work with a dietitian or nutritionist if you can, with an interest in MCAS, because if you can keep your diet otherwise as broad as possible, then that helps with your gut health. And I know there's a session coming up on supplements, but I've also found that some supplements can help, and probiotics can help, particularly if someone is on a very restricted diet. And the other thing that has, for me, I think is as important as everything I've just said is the nervous system support. So being very, very kind to yourself as often as you can through every single day. And that means having pauses between activities, not dovetailing everything you're doing, recognizing when you need a break. But, if you like doing breath work, that's brilliant. Gratitude practice. Anything that can shift you away from the fight flight mode, more towards a kind of parasympathetic, calm niceness, that can help with the immune system as well, because there seems to be a really close link, well, obviously, between the nervous system and the immune system. And when the body and mind feels that it's in imminent danger in this fight-flight mode, this adrenaline, cortisol mode, then not only are you getting a release of more kind of histamine and more kind of active mediators and inflammatory mediators, you're also down regulating all the other processes in the body, including hormones and digestion, and nicking all the common nutrients from those to keep you safe. And so if you can move yourself away from that state more towards the kind of calming, vagal, parasympathetic, whatever you want to call it, state, then that can help calm everything down, including actually the mast cells. And the interesting development, I think, over the last few years is the concept of neuroplasticity, and this ability that we have as children that once we thought that we kind of pretty much grew out of being able to create new neural pathways. Realize now that it's still possible as adults, and that can and has been shown to really help with MCAS symptoms, and again, just move you away from maybe these kind of negative patterns of neuronal activity that maybe the body's kind of trying to keep you safe by kind of repeating, but maybe aren't in your best interests at this point. I'm kind of rambling now, so I thought maybe what we wanted to do today is just listen to two ladies both with MCAS but with very different stories, and then use their stories to maybe think about some questions, and I think there are some questions that have come in before this session that we can answer as well, and pull it all together and maybe tease out things that I've forgotten to talk about. So first up is Denise, and what we thought we'd do is going to tell their stories, but with an emphasis, I suppose, on maybe the hormone side of things, because that's the theme of this evening. Denise.
Hi, I'm Denise. I'm 46 years old and started early perimenopause at the age of about 38 years old. And I have to say at the start, I had made no connection to the menopause, to all the symptoms I then started to get. I thought they were all separate, completely separate issues. So up until the age of 30, I was healthy, avid long distance runner. Had mild hay fever and urticaria at times, but nothing that really was substantial. The start of perimenopause, nothing happened initially really that I'm aware of, but then I started to develop IBS symptoms, so I thought I had some sort of IBS, again making no connection to menopause, and I noticed I became a lot more anxious. I always was quite anxious, but the anxiety levels were definitely going up. Then one night, all of a sudden, I became very sick, and I went to the out of hours hospital, and they gave me cyclizine, and I was straight back at the hospital within about 20 or 30 minutes because I took a reaction to the cyclizine, and they told me that I had an allergic reaction to it. The sickness went away, but the nausea continued. The nausea was there constantly. So they started to treat me for what they thought was acid reflux, and give me lots of PPIs, which really only made things worse. And eventually they put me on cimetidine as well. And I just remember that being really, it was like it was burning my insides, and I was really struggling with it. I was actually sleeping in a chair upright because the nausea was so bad that I couldn't lie down. I eliminated food because I was convinced it was something I was eating that was causing it. So I began eliminating food after food until I was practically living on cereal. I was dropping a lot of weight, and then I stopped running. I didn't have the energy for it. I felt dreadful. I isolated myself, stopped socialising, because I only really felt safe when I was in my own environment. So I stayed in my room and had a lot of time off work. I started to develop kind of like tic things where when I was anxious, I would start to tic, and that would make things even worse then about going out. Eventually, the gut symptoms became so bad that I went for a colonoscopy, endoscopy, and ultrasound. And there was nothing definitive from the colonoscopy or endoscopy, but they did find gallstones. But they didn't believe that was the cause of my nausea because I wasn't having the pain. Although at that point I was so desperate with the symptoms that I was getting that I was prepared to pay privately to have it removed, my gallbladder removed. Thankfully, I didn't. Then I started to develop heart rate issues where I was had tachycardia. That was monitored on a heart rate monitor, and I was having palpitations. They put it down to what they thought was a medication that I was taking for mental health, and they reduced one of them to the minimal dose and eliminated another one completely. And whilst doing that, the opposite thing happened. My heart rate dropped significantly. I was becoming extremely dizzy. And at that point, there was consideration for a pacemaker. Then the cardiologist asked me to do a treadmill test, and they could see that my heart rate did respond when I exercised. So they said just to monitor it, and perhaps it was coming off medication too quickly that caused this to happen. Then I got COVID, and straight after that, I got dermatographia and urticaria. That's been confirmed by a dermatologist. And then the nausea changed to what was like a burning sensation in my mouth and my throat. So by this point, I was exhausted. I was in a dark place. I couldn't cope with all these symptoms, and I didn't know where to turn next. That nobody could seem to figure out what was going on, because I was going to all different departments separately. I then reached out to a dietitian in Glasgow called Leslie Reid, and I was so anxious going to see her. I was so scared just about like the thought of reintroducing food, but we done it really slowly, and she was fantastic. She realised very quickly though that it wasn't IBS that I was suffering from, because I could eat the same foods, be okay, and then not okay. She had mentioned histamine intolerance a couple of times to me, and I'd never heard of it. So I was quite dismissive of it. And Leslie had got to know me, and she knew how anxious I was. And so she didn't want to push too hard on it for fear of me just saying, "Oh, I can't take this," and leaving. So she was very patient, and we worked together very slowly. And the pivotal moment came when I became really unwell, and I contacted her and I said, "I'm really unwell." And she witnessed the skin flushing, the high heart rate, the burning sensation in my mouth, throat, everything. And she then again mentioned, "Denise, I want you to talk me through your day first of all." And I told her what I'd eaten that morning, and that I'd been exposed to carpet cleaning chemicals, as there was carpet cleaning going on in my office. And she then presented me with symptoms of MCAS. And for me, I was reading a story about me. Everything just seemed to fit exactly what I was going through. She pulled me from a very dark place, because at that point I didn't know where to turn. She was the one person who put everything together. She looked at the whole thing collectively, and it directed me to people like Mast Action. She sent me to Chloe Hall, and then on to a private MCAS doctor. And when I was just seeing the MCAS doctor, I was actually seeing my gynecologist, again, still unaware that this is causing anything. And they changed my progesterone. They introduced more progesterone, and it really made such a huge difference. All the symptoms started to settle down. I still do get all the symptoms, but nowhere near as much as I used to get. I can't run anymore. I don't do that because that's definitely a trigger for me. But yeah, getting the right level of progesterone and on H1 and H2 blockers, but definitely progesterone made a huge difference. And also the medications I take as well for another condition happen to have mast cell stabilizers in them as well. So I'm quite fortunate in the sense that I've went through the whole process and been very unwell to a point where I now have some sort of a life back, albeit I've had to adapt to a new way of life, and I've had to have my environment and work changed, and I have to look out for triggers all the time and keep note of things. But definitely now, when I went to Chloe Hall and the MCAS doctor, Dr Taylor, they both recognised straight away that it was the menopause that had triggered all these symptoms and to cause all these systems to react the way they did.
Thank you. I also thank you so much for sharing your story, because it's, you know, it's full on, isn't it? Talking through what's happened. It's all relatively recent for you, and you were really, really poorly with it, weren't you?
Yeah.
Yeah.
That went on for several. I mean, I've told it all briefly, but it was over years that went on, and I just became so isolated because I was terrified of everything. I was terrified to put anything in my mouth. I was losing hope.
Yeah, I'm glad you're feeling better.
Yeah, me too.
And so thank you. And then just moving on to Margaret. Margaret's got a different story, and she's going to introduce herself, and also just make sure that everyone's happy to listen to it, I think. Is that right, Margaret?
Yeah, and basically my daughter said, Mom, you have to have a trigger warning. You talk about it in such a blasé fashion, but actually some of the things that you're talking about are pretty heavy and serious. So I've kind of written notes for myself because I wasn't really sure that I was going to keep on topic, because I've been ill for over 20 years, which I now understand to be MCAS, although I didn't have a diagnosis until fairly recently. Although it doesn't actually count as diagnosis exactly, because I got it from a gynecologist, and I also react to antihistamines and I react to mast cell stabilizers. So it's a kind of grey area whether it's exactly what I've got, although it's fairly clear from my symptoms that's the case. So my trigger warning is basically that I've had quite a lot of medical trauma. I've also going to talk about blood quite a bit, or potentially talk about it quite a bit. I've also had psychological difficulties. I also should mention that I have had suicidal ideation, which is another thing that I might mention. I might not get there, but it was as a result of the tablets that I was taking. So why am I actually sharing this? Because I'm really nervous. I'm sharing it because during my experience of this illness, I have been on my own. I didn't get diagnosed, or I didn't even know the words mast cell activation syndrome until 2022. But I have had problems since puberty. I've clearly got a family history of this kind of thing going on. I mean, I know stories about my mom and her great-grandmother. My mom had to have a hysterectomy in her late 30s for blood loss issues, which obviously I've experienced as well, but thankfully not the hysterectomy at the moment. And she always commented on the mood swings and difficulty and menstrual issues of my great-grandmother. So there's clearly an atopic family history, but also a menstrual difficulty history in my family. It's very clear to me that my mother had hypermobility EDS. I've had that diagnosed. My daughter's got it diagnosed. We also have thyroid problems in the family. So there's this whole sort of heap of comorbidities that are going on. So I'm going to start chronologically, actually, so I can make sense of it for people. Firstly, puberty. I never really had a normal cycle when I started my periods. I had really long periods. They were really heavy and they weren't precise. I mean, they weren't as erratic as they got later on, but they were not a cycle as such. Sometimes the 35 days, sometimes 28, really depended on what was going on in my life, what I was eating, looking back. And the heaviness of the periods has always been an issue. And subsequently found out some reasons as to why, which I'll go into a bit later. But so coming sort of from a really difficult time with puberty, I also had a difficult time with any medication that was given to me to change my hormones. So I was put on the pill for period pains and to try and reduce my blood loss. And I was so depressed on it. I gained about 1.5 stone in weight within a matter of weeks. It did not work for me. I went from being a really active teenager to being sort of stuck in bed. So I came straight off it. Thankfully, I bounced back. But from that point on, I was kind of on, I think it's called mefenamic acid and various other things to try and just mediate what was going on in my body. And so it's quite stressful, which I didn't realize, because you kind of think everybody's like that. But ultimately, I've drawn out for myself on this piece of paper the kind of things that are MCAS-y about that experience. And they're definitely my response to the medication, the heavy bleeding, and the fact that it's down to my genetics quite clearly, from my family history, and also from subsequent reading that I've done since I've jumped onto this Mast Cell Action fantastic group. So the next step, thinking about things that have really affected me hormonally, was childbirth. And that was, that's probably why I've put the trigger warning in. My experience of childbirth was very difficult. I had a 56-hour labor. I had an enormous baby. And I had an emergency C-section. And all through my pregnancy, I felt awful. I didn't get normal pregnancy symptoms. I got constant diarrhea. And it's really embarrassing. And that's why I'm flushing. It's not just because it's hot, but constant diarrhea through from pretty much the beginning of my pregnancy through to about a year after my daughter was born, when I finally saw a gastroenterologist and said, what on earth's happening? I must have been going 8 or 9 times an evening all the way through that period, on top of the horrible childbirth experience, on top of the fact that I must have been pumped full of different medicines at the time. And on top of the fact that I then decided I was absolutely adamant I would be breastfeeding my daughter because she was not going to have the allergies that I had. So it was really stressful on my body. So I think there was a lot of trauma. What I was going to draw out of that is, I think, having had a look at what's on the website and how people, the Facebook group, and how people interact about their lives, I think there is this underlying sort of response to trauma that goes on when you talk about the vagal nerve stuff and the parasympathetic system and so on. I think it's activated because of trauma. I had a traumatic birth experience. I also lost a lot of blood. So I had the blood loss, being weakened physically, which I think underpins also my mast cell reactions, because that's happened to me recently. And I was so much more sensitive when anemic. And there's some hypermobility stuff that was also involved in it, in terms of having a large baby and having odd scars and just not recovering normally. So it took me a long time. I came down with ME or CFS. I'm not sure what the technical term is now, because it was what it was called at the time, and sometimes people find the terminology a little bit offensive. I'm just going to call it what I called it when I had it. I had that for 6 years. I fell ill almost immediately after weaning my daughter. And I obviously went through a lot of hormonal changes. I'd been on demand feeding for 2 years, so I was shattered physically and mentally. And my daughter had problems with her teeth, again, possibly hypermobility related. And I saw a dentist with her, and there were issues there, and we stopped very abruptly. So there was also some trauma there, because that bond was sort of very challenged in that moment. And I'd had a very difficult birth experience with her and found bonding with her quite hard. So we moved house, which is a key important thing to say at this point, because actually it will come to the story later. Moved house, got there within 5 or 6 months. I had completely collapsed. I came home from the shops with my daughter in a buggy. I tried to get on a bus. The bus driver wouldn't take my £10 note, so I had to walk home. I got back. I had to ring my mum. I could only keep one eye open. I was almost passed out, alone in the house with my baby daughter. Thankfully, my mum lived locally, and I went into the beginning stages of ME. It also was accompanied by a massive menstrual bleed. So looking back on it, it's quite clear to me that I was actually having MCAS symptoms quite profoundly at that point. I was incapacitated. I was housebound for about a year, maybe a bit more. And then pretty much, well, actually bedbound for the year, sorry, and housebound for 5 years. I had a mobility vehicle, I had brain fog. I was quite young at the time. It was very distressing. I had this young baby that fortunately my parents helped out with quite a lot, or toddler, and everything got really difficult. And I went to the doctor. Sorry, I've forgotten the bit where I went to the doctor when she was a year old. So that was before the ME. I went to the gastroenterologist and I was put on an exclusion diet, which helped massively, but didn't prevent me from keeling over hormonally, I think, when I stopped breastfeeding and went into this new house. ME was sort of 6 years, very, very difficult. One of my friends had it. She said, you have to do the lightning process. So coming back to that sense of doing something to do with the limbic system and to do with calming your nerves down that Dr. Fletcher mentioned, I did the lightning process. I really didn't expect it to work, but within 3 days, I'd gone from needing 10 hours sleep per night and 2 in the afternoon to actually waking up at 7 in the morning, screaming my daughter, I'm awake, and rolling around on the bed. I had so much energy. It was unbelievable. It's just like a switch had flipped, and I could literally feel the buzzing in the back of my neck, like I was refilling. It was a very odd time. I had a lot of difficulties. I also had a lot of well, this is the hormonal side of it. During the period that I had ME, I had I think my periods were, there was no cycle. Sometimes I'd have 3 months off. Sometimes I've had 2 weeks of flooding. Sometimes I'd be spotting just non-stop, then have another flood. It was highly difficult to manage. I had no energy to actually pursue it with any doctors. I gave in and just stayed at home and coped with it. I was eating a fairly good exclusion diet at that point. So I think it was related to stress, it was related to inflammation, and it was related to being in that house. I've only recently discovered that that house has a hidden mold issue, which I think has been affecting me for years. But I'm not sure how much, because it's just such a convoluted and complicated story. I recovered from CFS. I had 6 glorious months where I did Pilates and learned to walk again, and I did the OU courses that I could do. My brain fog lifted. It was astonishing. I thought I was better. Then I got cocky and I made a birthday cake for my daughter's 9th birthday, and it was this big purple thing with loads of coloring, loads of icing, loads of allergens. I had 2 slices of that, and within a week I had had such a serious menstrual hemorrhage that I was in hospital. My hemoglobin level had gone to 5.8. I was waxy. I was very near death. And they gave me a blood transfusion. So I had a 4-pint blood transfusion. I came out of hospital sort of better, but not 100%. It took me a long, long time to recover the nutrients. And I was prescribed norethisterone to cover me for the period of time that it took for me to see the gynecologist. And during that time, I decided it was definitely the cake that had done it, which I was probably right about. And I quit sugar and I went, okay, this is ridiculous. I'm going to have to just look after my health properly. The norethisterone I was prescribed gave me black moods for about 3 or 4 days whilst I was on it during my cycle. And then I'd come off again, and then I'd go back on it, and then I'd have this black mood. And it was noticeable that the pattern was I always rang either my dad or my sister, because I trusted them to cope with the fact that it wasn't really me, it was the effect of the medication. But I didn't want to bleed to death, so I kept going with that. I was then put on a Mirena coil and had a biopsy done, which was all clear, thankfully. And the Mirena coil was good, actually, in many respects. I probably stopped menstruating entirely about 4 months after I first had it. It certainly made me heavier, and it made me mentally really slow. It made me forgetful, but it allowed me to function and to be a mum. And that was hugely important to me. So I just pushed forward. I had that for roughly 9 years. At the point that I decided I'd stop, it was about 2019. And I thought, my blood pressure is really high. Nobody can work out what to do with it. I've seen all these doctors. I've read this thing about the Mirena coil in America giving, I think it was intracranial high blood pressure. And so I thought maybe I'll take myself off it and see and put one back in 6 months' time if I need to. Unfortunately, that didn't work that way because I couldn't put one back in, because in the interim, that was 2019, 2020, there was COVID around. By the time that I'd worked out that I couldn't keep them in, my daughter had long COVID. I'd been exposed to COVID. I was clearly something immunological going on. And I was very stressed because obviously the first lockdown was rather stressful for everybody. And not least for someone whose daughter had actually come down with COVID in the first wave. So the whole experience of COVID and a lockdown and everything else that happened in that time and all the stress, I ended up bleeding the coil literally out of my uterus. It just wouldn't stay put. I tried twice because I couldn't sustain the blood loss and I was quite seriously anemic. And obviously I was dealing with my daughter as well, being very poorly. So I felt I had to do something. I couldn't just take it. And eventually, I also should say, I did go and have the jabs. After the second jab, I had absolutely horrific blood loss, which was just a week after the second jab. I'm very clear that my body couldn't take it. I'm not an anti-vaxxer. I understand that some people, would feel that talking about it was a negative thing. But for me personally, that just tipped my body over. It couldn't cope with it. It wasn't supposed to be there. It didn't like it. And I had this heparin reaction, I now know. That led me to Professor Kuller, who I'm mentioning because he was fantastic. I went to see him in April 2022. I was a wreck. I walked in the room, I gave him my history. He looked at my face. He looked at the fact I've got cherry angiomas. He looked at the fact that there was this sort of, I was explaining to him that the composition of my period was really odd. And he just set me down. He said, have you heard of mast cell activation syndrome? This is what I think you have. He'd just been to a conference about it. He talked about the little angiomas being potentially diagnostic. He talked about research that had suggested that people in a flare produce a lot of heparin. The thing that tells me that he was right about the heparin is whenever I had a blood test at that point, my whole arm would be covered with blood. Since then, since I've gone low histamine and on his advice in that appointment, that hasn't happened to me. I can't tell you how much I am grateful to that man for actually saying, go on the diet, do it properly. It's not just the exclusion diet you've been following. He'd kind of looked at the foods that I ate and he said, all the ones that you're naturally deciding to exclude have high histamine. I know I'd been at that point to an allergy specialist who said I hadn't got MCAS because my DAO levels were high enough not to consider having that as a diagnosis. But actually, it was clear to him that that was what was happening. The heparin, I think, and this is my conjecture and my experience, I think what happened every time I had a period that I was having when I had high histamine levels and wasn't coping with it, I was getting the heparin reaction, and then I was losing so much blood that actually I had other deficiencies coming, nutritional deficiencies coming, and they made the blood loss a lot worse. I read somewhere that a vitamin A deficiency can cause or is implicated in menorrhagia. And so I started eating liver once a week and actually improved my situation quite a lot. Then I was referred quite shortly afterwards to someone called Dr. Lulseged, who again, he's a very nice man. And he helped me by suggesting I went keto because my liver enzymes are very high, which fits with the MCAS profile. My triglycerides were very high. My body wasn't happy. I lost quite a lot of weight. I found keto incredibly difficult to follow, but actually it was worth it because my hair started coming back, my periods weren't as bad, everything got a bit easier. So, and then the final bit of this story is that in December, so I was going okay, not brilliantly, but okay, recovering, getting a bit better. Had a bit of a blip when my mum passed, and there's obviously a huge amount of stress related to that. So I menstrually, that was quite hard. But actually, I then found out in December that we had this massive plume of mold underneath our kitchen floor. And our house is a Victorian semi, and it had mold in other places as well. We've now established with help of some specialists, sort of remediation people. And that the reason I am very, very clear that that affected my hormones is I left at Christmas. I went back in January. I was in my house for 90 minutes collecting sentimental things I needed. And within 90 minutes, I'd gone into my house at the very, very end of a period. And within 90 minutes, I was flooding. And I came back and I was so unwell, actually, that I found I couldn't walk up the stairs to my bed. So I was stuck on the sofa for 3 nights. And I was really anemic. I ended up having to go on norethistone for 2 or 3 cycles to recover, which left me with the aforementioned suicidal ideation. But it became very, very clear to me that the thing that has triggered my MCAS in that scenario and the hormonal difficulties has been my interaction with the mold exposure. And I read about various types of mold that can actually mimic estrogen. So I've got a kind of fake quasi estrogen dominance going on based on my exposure to my house. And I'm wildly sensitive to the smell of mold. My husband's been going to and fro, and I can't have him near me. He has to shower before he is allowed to wander around the house. I've not allowed him to bring anything here because I am that sensitive. And actually, I have been healing quite a lot. So I came down to this and I thought, whoa, that's all really negative and difficult. And I thought I'd try and finish with a few things that I learned that are positive about the experience I've had. Firstly, I am very clear that I look after my body really well compared with how I did. And that makes me think that I should probably also say that in terms of food, I still have a very restrictive diet. It helps me massively. I'm not eager to try new things. I have talked to a nutritionist who I think is fantastic. And I think when my body gets stronger, I'll be able to try new things. But at the moment, I've got to focus on fighting the mold and also maybe getting a bit of sunshine and living a healthier life that way. So screen time, that kind of thing, all those boring things that you think, oh, I really don't want to do that. That's the stuff that I've got to focus on next to make some progress. But I do feel that now I don't drink, I don't smoke, I don't do anything that hurts my system. And actually, if I can just fight the mold, I'll come out of this sort of stronger than I might have done had I just lived my life. It's also allowed me time and space to look after my daughter, who is autistic. And I could do that without judgment. I mean, it's very difficult to stay at home when your husband and you met at university and there was an expectation you'd go and have a career, but actually this is giving me the space to do what I needed to do for her without feeling I'd actually compromised on anything. And I'm looking at the time and I'm thinking I should shut up soon. But I do think that, yeah, there's something else that I really need to add in terms of supplements. Also, when you talk about stress hormones and so on, I just spoke to a really lovely nutritionist lady who said to me, my HPA axis is off whack, which is your hypothalamus pituitary something or other axis, and it's to do with stress hormones. And basically the idea is that if you're that stressed, then your other hormones aren't going to get the nutrients they need to use them properly, so that you're deficient in things that will stop you making your testosterone, DHEA, estrogen, etc. So in terms of what Dr. Fletcher said, stress reduction is really key, really key. Yeah, I think that's about it. I think I'm done.
Amazing. And thank you for sharing. Really, really thank you, because you've been through it for years and years and years. And again, it's really brave that you've felt able to share it to everyone here, particularly as there are so many people. But I think there'll be lots of people who some parts of their story, your story, will ring true in terms of where they're at or where they've been. And I think it's really good to share. So thank you. So I think, Joy, do you want to throw some questions at us?
Yes,
If there's any kind of themes. So I'm aware of time, but I think we can go for a little bit longer, can't we, to answer some questions?
That's what I was going to say. It's 8 o'clock, so I'm aware some people have private messaged me just to say that they're shooting off. So if everyone's happy, I'll record the Q&A. If anybody is featured in the Q&A and doesn't want their part to be put on the YouTube channel, if you message me and let me know, then I'll make sure that we edit that bit out. But actually, the Q&A will probably be really helpful for lots of people who have similar questions. We had pages of questions submitted before the session, but I think it might be sensible for us to work through what's been put into the chat today and then move on to those questions if we have time. If we don't get to them all, then we'll work out, you know, how we best sort of move forward. I'm just going to spotlight Dr. Fletcher. There we are, so everyone can see you in all your glory. What I'll try and do is skip any questions that aren't specifically related to women's health, but we can perhaps take those questions in and I'll see if I can get back to you with a response if anybody's asked anything that's not specifically related. So hi, can I ask about overactive bladder, perimenopausal and MCAS? Not sure what is causing it. What would you look into?
Well, I mean, I suppose I'm coming from it more from a perimenopause point of view. And I think trying things that are quite simple are a good idea. So it's a really common symptom of the perimenopause and menopause. There's all sorts of urinary symptoms that go with the hormone changes in that time. And so I would go in with a trial of some vaginal estrogen in the first instance, because it's normally not absorbed particularly, and it can be really helpful in terms of just adding back the estrogen that can cause the cell changes that leads to the urinary symptoms in the first place. I think also it's really important to know that it is a kind of symptom of MCAS and interstitial cystitis, and there's all sorts of things that are related. And so I think if kind of simple measures don't work, then and you have MCAS as a diagnosis or suspect that you do, then I think that's an avenue that you need to go down and see a specialist with that as a question, and ideally see a specialist who has an interest in MCAS and urinary symptoms.
Lovely, thank you. The next question: since testosterone is a mast cell stabilizer, do you find this is helpful as HRT? And
well,
also
I mean, in my mind, it is
progesterone.
HRT, and yes, and I didn't really talk about testosterone, but it was on my list to talk about it. I have had people where it has transformed their lives, literally, and it's been the one thing that has made a massive difference. I've had other patients where it hasn't actually, and there's been some who have reacted to it in terms of an MCAS flare, but I've seen, it can be transformative. So it is something to cautiously trial. And I don't think there's one preparation that's better over another in my experience. But if you are going to try it, then you do what you probably would do with any new medication or any new supplement with MCAS, which is to go in at a much lower starting dose than normal and build up quite gradually, and ideally just change one thing at a time so you know whether or not it's helping.
Thank you. And we've got the same question about progesterone as well.
Yeah, I mean, I love
Same
progesterone,
answer.
natural progesterone, which is important because synthetic progestogens don't have the same action. And I do think it's interesting with Margaret's history that I do see a lot of people with MCAS who have progestogen sensitivity. Which doesn't mean that they can't tolerate progesterone. Some can't, but a lot of people can, because it is different, and it does seem to be significantly mast cell stabilizing in some, and again can make a big difference. And I do prescribe it on its own now, and I do prescribe it if people have had hysterectomies, if they've got a history of MCAS as well, because with the British Menopause Society guidelines, unless there's a diagnosis of endometriosis, if someone's had a hysterectomy, then it would just be estrogen only. But I do find that the natural progesterone works really well for lots of people without diagnosis of MCAS as well. So I'm a big fan.
And then the next question, does perimenopausal mood, depression and anxiety tend to improve or stabilize when estrogen drops off after menopause?
Yeah, that's an interesting question. I think it can be different for different people. So some people respond badly to the fluctuations in the perimenopause, and then when things even out in the menopause, they feel better. I think a lot of people will be on a bit of HRT at that point, and actually just leveling off the hormones with the HRT and just giving that more kind of consistent level rather than the fluctuations can really be helpful in terms of mood. I think bringing up estrogen levels can help with mood. So and I also think it's a real transition, the perimenopause, and I don't think people really appreciate the impact it can have before they've experienced it themselves in terms of their lives, how they feel about themselves, whether or not they recognize themselves, what it does to their minds, their brains. Brain fog can be hideous. Everything can be affected, and that pushes up stress, and that pushes up self-doubt, and it can affect confidence and self-worth, and it can be a real kind of turbulent time. And actually, the body is really good at eventually compensating for the hormone changes, and that in itself can help people feel better, but it can take years, which I think is why there's been a focus on HRT more so than maybe there has been, particularly since the big studies that raised concerns about it, because I think it can help some people significantly. And actually, I think it can help people with MCAS significantly as well. Not everyone. But I think with Denise's story, one of the questions I did see pop up was with whether it's progesterone on its own, and I think you had a patch as well, didn't you? So you've got estrogen as well as the progesterone.
I've just seen there's 33 new questions have popped into the box, so we may not get to all of those, but we'll keep going for a little while. Is estrogen dominance connected to this for people? That may have been about a specific point that somebody was making. Heavy bleeding, migraines, anxiety, depression, PMDD.
Yeah, so estrogen dominance isn't a term that's recognised by the British Menopause Society, although a lot of other health care workers and functional practitioners use. And I don't think there's a huge amount of research about it, but I think what it kind of relates to is progesterone levels being, I suppose, proportionally lower than estrogen levels, and that kind of mismatch that you can get, particularly at various points of the normal menstrual cycle. So at ovulation, where you get a peak of estrogen, and also actually in the run up to the period. And so there is, and so I do think that plays a part in terms of what progesterone tends to do and what estrogen tends to do, but you can get symptoms from high estrogen as well as low estrogen. It's in the ones that you've listed. It can go both ways. So it is quite tricky to work out what's going on. As you progress through perimenopause, estrogen levels do drop off and become quite low in the menopause, and in the early perimenopause, then they can go quite high and can be higher than actually what you've experienced, sorry, as a fly, in your normal menstrual cycle. Not as high as normally in pregnancy, but in pregnancy, as I'm sure most of you know, you get a real increase in your diamine oxidase levels to kind of buffer, I suppose, the effects of the high estrogen on histamine, because you don't really want high histamine levels in pregnancy. So that's one of the reasons why some people have quite significant problems in pregnancy, and there are genetic SNPs, so these small changes in our genetic makeup that can mean that our diamine oxidase levels are maybe not as active as for others, and that can be a problem in pregnancy and may be one of the reasons why people with histamine intolerance, MCAS, can have quite a tricky time in pregnancy.
That's really interesting. So we've got lots of questions about mold, which I think maybe we'll look at kind of outside of the session and see if there's anything we can put together and try and stick on topic. So is testosterone relevant for women not in menopause?
There's no reason. Yeah, I mean, the whole testosterone thing is frustrating. Women have testosterone, it drops off late 20s, early 30s quite gradually. But it's just not been researched in women particularly. There is some research coming through now in the perimenopause and menopause in relation to testosterone, but there's just nothing. I don't, as far as I'm aware, at other points in a woman's life. I may be wrong on that, because I say I specialise mainly in the menopause. But it is really interesting, isn't it? Because it can, as I said earlier, it can really help some people, and it'd be interesting to know if it would help people at different ages. And at the moment, there's no research.
Okay, we've got next question. I can't tolerate progesterone or estrogen. Is there anything else I can try? Wild yam cream I've heard of.
I suppose another part about my journey is that I've started looking into more integrative medical options, because I realized that my toolbox was quite limited in what I could do, what I could offer. I do think it's worth trying various things, but I also think that there's very little research to back it up. So I think it would need to be on an individual basis. I think it's also worth exploring HRT in really minute detail, because I think often you can go in with completely different doses, different products, different routes of administration, and often, not always, and you may have tried everything, but often find something that works and that is tolerated, a combination that's right for you, and that's going off guideline. But I do think it's worth exploring, and I suppose I'm hesitating as well, because there's also things like progesterone creams, which again are not in any Menopause Society guideline, because of concerns about how consistently they're absorbed, because you're really using progesterone to keep the endometrial lining thin from the effects of the estrogen, because the estrogen thickens the uterus lining. We now know progesterone does an awful lot more than that, but that's what the guidelines have it as being in the HRT regime for. And so progesterone creams are more of a bioidentical HRT option, and they can still be really helpful for MCAS. So it depends a little bit on what else is going on, but that's one option. Yeah, there's lots of things you can try, but it's trial and error, and it's really good idea to have someone who understands MCAS and hormones and can be on your side through it all, and patients as well.
Thank you. Is eutregestin, I don't know if I'm pronouncing that correctly, a natural progesterone?
Yeah, so eutregestan is a natural progesterone, and it's licensed for HRT. But it's also important to say that there are other natural progesterones that are licensed for other indications, for example, fertility treatments. And for some people, it's a really good point. Thanks for that question. For some people, one of those other natural progesterones, even though eutregestan is natural as well, can be better tolerated, and significantly better tolerated. And it may be because of other things that are in it, so the excipients that are in the preparations, it may be the route of administration, it may be that you can maybe, you know, adjust the dose a little bit easier. But yeah, that's really important. That's a really important point. And I think the synthetic progesterones, so northisterone, Mirena, a lot of the combined HRT preparations, they're synthetic progestogens, and they act in a different way in the body, and they're broken down in a different way in the body. And so they can have side effects that a natural progesterone wouldn't necessarily have, and they can be really helpful. So it's not to say that you shouldn't be on them, but they don't necessarily have the benefits that the natural progesterone has. They're not broken down into the same active metabolites that you can get benefit from. And they don't seem to, as far as I'm aware, have the mast cell stabilizing properties that the natural progesterones have.
Amazing. Okay, we've got a question from a question. What do you recommend for puberty and hormone imbalances and period issues? The GP's first port of call for period issues is the contraceptive, which will have synthetic progesterone. Are there natural alternatives? We're not looking for contraception either. So I know this is a common thing that comes up for sort of teenage girls who are.
And I'm looking into this for a friend's daughter who is having an absolutely horrendous time. And there's very little out there, both in terms of research and in terms of specialist input for teenage girls in puberty. It's just horrible. And as a GP, that's what we would do. We would think about the pill. Yeah, it's really tricky. There are some newer pills that are probably better to consider. I think that's another reason why I'm going in the direction I'm going in, because I think it's worth looking at nutrition, and it's worth looking at an integrative approach, looking at every aspect of lifestyle, diet, just across the board, and supplements as well in that situation. It may be that the pill would be helpful, but there's some concerns about the effects of that long term in terms of hormone health, and again, that's more in the functional world rather than my world as a GP, but the more I look into it, the more I think that there's validity there. So it's really tricky, but I think trying to find someone who can help in a more holistic way is probably a good way forwards.
That's a great question. If you already have MCAS, how do you know if you're heading into perimenopause when the symptoms are similar?
Yeah, so hard. I think a lot of people don't recognise that they're going into perimenopause, regardless of their health beforehand. And I mean, I know I didn't. It's one of the reasons I'm doing this job is because I hit a brick wall and had no idea what was going on. And I'd done women's health as a GP. I'd actually done the British Menopause Society theoretical course. And I just thought I was too young, which is absolutely ridiculous. So I think it's really hard when you've got MCAS symptoms, but I think what can happen is everything can just go out the window and just go, you know, horribly wrong, actually, or just your symptoms can get a lot worse, or you may find you've got new symptoms that you've never had before. And I also think the age is a real clue, because, as I said, 51 is the average age of the menopause, and bearing in mind that's average, so there's people who are younger and people who are older, and menopause is you're after your last period, and the perimenopause can be anything up to 10 years, sometimes longer before that. So that's kind of early 40s. And I think most people at that age don't necessarily think that they're anywhere near it. And also life can be kind of full on, jobs can be full on, responsibilities, aging parents, kids getting older, all sorts of other stresses going on that you can blame on why you're feeling bad. But I think it's just having that awareness that it may be the perimenopause, and that it's not necessarily you being a bit rubbish when before you were kind of all right. And if your symptoms are different or worse, or you've got a flare of MCAS and you haven't really changed anything, then perimenopause is a really good, it's a really good thought. And then it's a case of, I would say, keeping a record of your symptoms, and what you're doing, and any particular triggers, seeing if there's a cyclical nature to them. Bearing in mind, cycles will vary and change in the perimenopause, particularly as you progress through. So that might not be as easy as it was when your cycle was regular, if you had a regular cycle. And then speaking to someone who knows what they're talking about in terms of perimenopause and hormone health. And ideally, if you have MCAS, someone who has that combination of interests. Because then you're going to get someone who's going to look at it from both angles and try and piece it together. And it's not easy to work out where to start, but there are some themes that the more people you see, the more you pick up, and you get a feel for where to go for that particular person sat in front of you. So there's an experience element to it, but yeah, it's not easy.
That's great. How do you feel? Do you want to do a few more questions, or
I'm okay.
You're okay? Okay, we'll
Yeah.
keep going for a little while then.
I'm okay.
I've noticed that you probably need a break. You're bombarded with questions. I noticed there's a few people that have left. So if you are needing to shoot off, obviously it's being recorded, so you'll hopefully be able to catch up later on. We've got 63 new messages, so I don't think we're going to get through all of those. If you come off HRT, will MCAS symptoms flare post-menopause? And if so, is that a reason to stay on it for life?
I don't think there's research on it. So I think I'm going with my opinion, such as it is. I think there's a chance that MCAS symptoms may flare, but I also think that if you come off things very gradually and talk it through before you make any changes, and you're in a good place when you're making that decision, then I'm not convinced that they're going to flare as much as someone may worry that they might. It's interesting about staying on it or not, and I think that's quite controversial, really, even in people without MCAS, because all the time you're on it, that you're getting health benefits that have been shown in studies. Bearing in mind, women's health is not particularly well researched across the board, and menopause, really, well, any aspect of women's health isn't particularly well researched at the moment. It's getting better. So HRT helps protect against osteoporosis. It helps protect against cardiovascular disease. It seems to help with brain health, possibly reducing risk of dementia, at least in maybe some subpopulations. It seems to reduce overall mortality rate, which is quite good. People tend to feel, often when they're feeling good, they feel better on it, so they're more sociable. That's good for health. They're more active. They tend to eat more healthily, and painting kind of this perfect picture of HRT, and that's not the case at all. But there are lots of reasons why you would think that maybe you would continue on it, and the NICE guidance certainly used to be that you could be on it for as long as the health benefits outweighed any risks with an annual review, and so you could argue that it's a good idea to stay on it. But some people don't want to, and that's absolutely fine. And I think the research isn't there to say everyone should. And I think in that instance, it's a case of reducing down gradually, bit by bit, and not just stopping it suddenly, and focusing on self-care and diet, lifestyle, and the nervous system support that we've talked about this evening, and just, I suppose, that kind of positive attitude as well. And I know that is easy for me to say. I don't have MCAS, and I think that's often really hard when you've been feeling so poorly for so long and everything seems to be up against you. But I do think when you're facing an unknown, like whether or not you're going to get a flare from coming off the HRT, I think if you do it in a way where you have confidence that the chances are it won't happen, and have your head in that zone, then I think that can really help reduce the risk of a flare. But that is my opinion.
Great, thank you. The next question is progesterone at a higher dose beneficial for MCAS?
Yeah, it's all the controversial questions, isn't it?
Yeah.
Yeah, in my experience, I've had people on higher doses and they've felt benefit at the standard doses, and again, not for everyone, but when they've gone up in doses, had another marked benefit in terms of their symptom control. And there again, as I said earlier, there does seem to be a bit of a connection between progesterone sensitivity and MCAS, and there is some evidence that it's almost like a U-shaped curve. So for people with progesterone sensitivity, they may be able to tolerate very low doses, not tolerate the standard doses that are licensed for HRT, and then be able to tolerate really kind of quite high doses. But at the moment, the research isn't strong enough for it to be in any guideline. But it is something that I have used in a select group of patients with good effect, actually. And again, sometimes it's the thing that's really helped when other things, everything else hasn't, and the kind of standard doses haven't, and the low doses haven't, and those doses have made things worse. So again, it's one of these things where it's very much on an individual basis to consider, but it is something to consider, in my opinion.
The next question: right before my period, I'm bedbound with weakness. I cannot move, I cannot breathe, as it's so much of an effort to even breathe. Is this normal, usually in the days right before my period?
I mean, it's difficult to say, isn't it? Because that's, I don't know you, and we haven't spoken, but symptoms are often worse in the run up to a period, so it would fit. And you've also got to think of PMS as well, and that links in, and symptoms of PMS get worse towards the period and then tend to ease when the period comes. And so I mean, I don't want to say it's normal because it sounds awful, and no, it's not normal. And it's something that ideally, if you can get some support and a medical review from someone who understands MCAS, I suppose, and hormones, then it's really important that you do. But it would fit with a hormonal pattern if that's when you're getting it.
Thank you. So I'll try and avoid any sort of personal ones and stick with more generic questions. So is there any link between polycystic ovary syndrome, excess estrogen, and MCAS?
Don't know. I don't know.
Yeah,
I don't.
Yeah.
Thing.
I think, like anything, there's lots of research needed still. There's lots of unknowns, isn't there? There's anecdotally there'll be.
Can I jump in for a second? I actually have polycystic ovaries, or I have the syndrome anyway, but it's actually it's helped by diet in particular. And I have had scans where it's been evident, and I've had scans where it hasn't been evident, and they've been quite shocked. And that's been when I've been eating less sugar generally. But yeah, I suspect, given that my family history is what it is, it's supposed to be 50-50 whether a child gets polycystic ovaries, female child. My sister doesn't have it, and she doesn't have MCAS. So, and she is atopic. She does have eczema, and so she's got the tendencies, but she doesn't have the full-blown symptoms. So I'm wondering actually whether there might be, again, that's really anecdotal, but it would fit for me.
Yeah. And I think there's some genetics that you could consider as well that would fit. So yeah, it's certainly possible.
When seeing a new gynecologist who you don't know and you don't know where they stand with respect to MCAS, what should you say in the first appointment to get them thinking in the right direction?
I think more people are becoming aware of it. So I think chances now of someone being at least being aware of it as a diagnosis are probably greater than they were even a few years ago. I think it's worth sitting down before you go and writing down your brief history and particularly any cyclical changes in your symptoms. So keeping a symptom diary is a really, really good idea for, ideally for a few months before you go to the appointment, so that you can then show that there is this fluctuation in symptoms that is hormonal because it fits with your hormonal cycle. And I think marrying those together and actually pointing them out in a nice, kind way helps someone to consider the two together. And also I think it's worth, and I know there's some resources on Mast Cell Action website, but it's worth taking along something that actually explains what MCAS is, because if I didn't know about a condition as a GP and a patient brought in some information, I would read it and I would take it very seriously. And I think most doctors are like that, really, because what they're wanting is to really help the person sat in front of them. And I think sometimes it doesn't feel like that when you have something that is not necessarily recognised as a condition or hasn't been for a long time. But I think taking along something that's really quite brief but gives an overview and maybe a direction to something in more detail that they could look at if they're interested is really useful.
Amazing, thank you. Sorry, I'm just scrolling through because actually there was lots of conversation in the chat, so I'm trying to whiz through. I think we may be near the end. What advice would you offer around removing a Mirena IUD? There is risk because hormonal changes are a huge potential trigger, but there is also potential benefit because artificial progestins are not helpful for MCAS. This is something you can wean off, which is the usual advice when stopping a medication.
Yeah, I do think actually Mirena can be helpful. So I think it can work both ways. Because I think for some people it can stop ovulation and therefore for some people it can help kind of calm down the natural variations that happen, hormone variations that happen in a normal menstrual cycle. So actually it thins the lining of the uterus, but also for some people it can help with the hormone fluctuations that are causing some of the symptoms in the first place. So I don't think you necessarily need to remove the Mirena for that point of view. Again, it's really tricky, isn't it? Because at some point it would need changing anyway, regardless of what your thoughts were on it, and you can't reduce down your dose. And I think it goes back to what I said earlier. You have to ideally optimize as best you can everything else, and go in feeling that it may not have the kind of catastrophic effect that you think it might. Do you know what I mean? If you've got it in, at some point you're going to have it taken out, and it's really tricky. Sorry, Margaret.
I wanted to just jump in and say I was advised, although I didn't have it done, to have a Kylena coil, which is apparently a much lower dose of progestin. I only heard about it from Professor Kuller. it wasn't done because I was, I was ejecting them. But I think the doses was something like it was 56 milligrams with the Mirena, sorry, and the Kylena was 19 milligrams, whatever it did. So it was obviously a much lower dose. I don't know how widely available it is, and that was obviously with
No,
the
it's
private
available.
consultation.
Yeah. Yeah, it depends why you're having it removed and what you're needing it for, because it is a really good contraceptive. And if you're not wanting to get pregnant and the MCAS and pregnancy we haven't really covered apart from Margaret's story, but it can be quite rocky time, and it may be that a pregnancy is not what you're planning or wanting. And Mirena and Kylena and all the different coils are very effective as contraceptives. So the synthetic progestogens are not all bad, but they don't necessarily, as I said, kind of offer the benefits in terms of the MCAS benefits that we've talked about. And there are people where certainly for HRT, we do tend to start with the body identical hormones first before moving towards the synthetic progestogens. And often, I often stick with the natural progesterones and natural hormones, body identical hormones. But they're not all bad. They're there. They've been developed and they've stayed for a reason. But it's again, it's just a discussion that needs to be had with your health professional.
I think with them, we've just got one last question that I can see. I may have missed some because there was a lot to skim through. So if I have, we'll hopefully pick that up when we go through sort of the chat at the end. But the last question was, does long COVID cause the start? I think maybe can long COVID cause the start of perimenopause?
Yeah. I mean, again, limited research for obvious reasons, but yeah, it certainly it can affect the ovary production of hormones, and it can exacerbate the perimenopause symptoms even if you're in it, and it can bring it forwards, and it can change your cycle as well, and the quality of your periods. And often those changes go back to normal, but it's there's an understanding that it can bring forward perimenopause.
Yeah. Thank you for answering all those questions. That was amazing. I know we've got pages of questions that were submitted before, but I think maybe we need to think about, we definitely need a breather and maybe something to think about, moving forward, how we approach them. And hopefully some people have submitted them before and we'll have then asked them in the chat. So we may have covered a lot of them. Lots of lovely thank you messages popping up in the chat, which is lovely. I'm going to share 2 links with everyone. One for our survey so that you can just share a little bit, your thoughts on today, and if it was helpful, and if you think we can do anything better. Please don't judge too harshly on my admittance to the meeting. It's always tough when there's lots of people to let in, and just to keep things secure, we obviously have to make sure that we're going through the register. And then the other one is the other events that we've got coming up. There's still a few more I know we've only got sort of a week left of Awareness Month, but there still seems to be loads of sessions happening this week and next week. So I'm just popping them in now. If you want to book on any other sessions, and if you could just take a moment, I think under 2 minutes, you'll be able to do the survey, and I'd really, really appreciate it. It means a lot to us. And of course, we have to say a huge thank you. Thank you to Dr. Fletcher for giving up your evening and for sharing your expertise. And thank you to Margaret and Denise for being so brave and sharing your stories, because I know it's a really hard thing to do, to put yourself out there and share some of the most difficult times you face. So we really appreciate it, and for all of you for giving up your time and trying to help. So thank you, guys. So if anybody doesn't have any questions that they wanted to add, you can always add them to the survey if you pop them in there, but we will try and go through. There's just a note from Beth, and I saw Beth Myers is lurking and has responded to a few chats. Just a quick note, Ari Marina and other inserted medical items, mast cells seems to extrude them. So that's
Interesting.
interesting. So yes, thank you all so much. Thank you to everyone for coming. Sorry that we overran, and thank you for bearing with us. And yeah, thank you guys for giving up your time. We'll see you at another session soon, hopefully.
Thank you.